there are two things that we can save someone's life. You just heard one, vertebral artery injury, and the second is what I'm going to talk to you about right now. Fortunately, I've never had to do this that I'm going to talk to you about, but I'm always ready to do this. And just as I've never had a vertebral artery injury, but every cervical spine operation I do, I'm always thinking about where the vertebral artery is and what I'm going to do to access it. And just as Tom said, how to control it, how to get above and below that injury if I do injure it. And these are the things you need to think about all the time when you're doing cervical spine surgery. What is the worst thing can happen, and what am I going to do to mitigate that?
Anterior cervical discectomy and fusion is one of the most common operations we perform as cervical spine surgeons. It is a highly reliable procedure, routinely performed in less than an hour, and commonly in an outpatient setting. The outcomes are consistently superb for the treatment of focal radiculopathy, as evident in this young woman with a left C7 radiculopathy. Despite its overall high success rate, complications may occur after or during anterior cervical spine surgery. Every surgical and every medical procedure carries its own specific risks and potential complications. 2 years ago, a very high-profile media campaign was launched targeting outpatient surgery centers. The journalists described in horrific detail gut-wrenching deaths that occurred after anterior cervical spine surgery. The common complication in these cases vividly recounted as patients, quote, gasped for breath like a fish out of water, and postoperative nurses not knowing what to do, therefore calling 911, was a retropharyngeal hematoma. This is a patient of mine who presented 5 days after outpatient anterior cervical discectomy and fusion at C6-7 with dysphagia and difficulty breathing. Significant retropharyngeal soft tissue swelling is clearly evident on this 5-day postoperative X-ray. I immediately took her back to the operating room and did not find an obvious source of bleeding, and she did well postoperatively. The outcome, however, could have been much different. The media assault on outpatient anterior cervical surgery 2 years ago made us think about our protocol, which we have developed over the past 25 years, performing outpatient anterior cervical discectomy and fusion with instrumentation. As cervical spine surgeons, we understand retropharyngeal hematomas and the potential catastrophic outcomes which may occur if not managed properly. But do our anesthesiologists and recovery room nurses understand the importance of assessing for this occurrence? And do they know what to do if they encounter a possible retropharyngeal hematoma? We created a simple quiz for our nurses, anesthesiologists, and surgeons at our high-volume outpatient spine surgery center. As expected, the spine surgeons were very comfortable assessing and treating this complication, but the nurses and anesthesiologists were overall highly uncomfortable. The nurses were unsure exactly what to do, who to call, and what equipment to bring to the bedside if they were concerned about a postoperative hematoma. The anesthesiologist only focused on endotracheal intubation in the patient with airway distress and were not comfortable with opening the incision to digitally remove the hematoma or an emergent cricothyroidotomy if they were unsuccessful with their intubation attempts. As for the surgeons, they were all comfortable with immediately opening the incision to digitally drain the hematoma if endotracheal intubation was unsuccessful. But they were unsure of the contents of the Emergent Airway kit on the crash cart and the complexity of the kit, since they were created for percutaneous airway access over a guide wire, and for our purposes, it is actually quite easy for us because the medial aspect of our anterior cervical incision is at the cricothyroid membrane, which is quite easy to expose after opening the incision for the digital hematoma sweep. So we only require a very few of the items on the kit on the crash cart but the initial presentation upon opening the Emergent Airway kit may be confusing. Also, the scenario in the operating room may be different because the crash cart is usually not present, but routine anesthesia cart tools are adequate. We put together a protocol for emergent airway assessment and management after anterior cervical surgery and showed it to our nurses and anesthesiologists. We then gave them the quiz again, and they overwhelmingly demonstrated competence and comfort with assessing for retropharyngeal hematoma after anterior cervical spine surgery. The Cervical Spine Research Society Special Projects Committee vetted this protocol, and I would like to share this with you. Hi, my name is Rick Sasso. I am the president of the Cervical Spine Research Society. On behalf of the board of directors and all of the members of the Cervical Spine Research Society, we would like to share with you this educational video that will help assist you, your anesthesiologists, your recovery room nurses, and all of the medical personnel who help you care for your patients after anterior cervical spine surgery. This streamlined approach to the evaluation and management of potential airway compromise after anterior cervical surgery is a rational step-by-step algorithm to efficiently secure the airway with a retropharyngeal hematoma. I thank my fellows, Drs. Ryan Snowden and Tyler Jenkins, who you will hear in the upcoming video. I also thank Dr. Gregory Schroeder, who is the Cervical Spine Research Society Chairman of the Special Projects Committee. And I especially thank Dr. Alex Vaquero, the past president of the Cervical Spine Research Society, for his unwavering support. We believe this streamlined approach will benefit you and your medical staff effectively manage the very rare but potentially catastrophic outcome of retropharyngeal hematoma after anterior cervical spine surgery.
No strikeouts in anterior cervical surgery airway management, a streamlined protocol. Thousands of anterior cervical discectomy infusions are performed yearly in outpatient surgery center. This is the most commonly performed operation to treat symptomatic cervical pathology. ACDFs are performed on an outpatient basis to improve patient outcomes and reduce the cost of care significantly when compared to inpatient hospital stays. When done in an outpatient setting, ACDFs are extremely safe. In a study by Dr. Sasso and Dr. Geringer, over 600 ACDFs were performed with a significant complication rate less than 1%. Requirements for outpatient ACDF are fairly strict and require that patients be observed for 4 hours postoperatively. They also require a significant and thorough neurologic exam prior to discharge and are only discharged home if the patient has the support of a competent adult caretaker. We also recommend surgery center adherence to the no strikeout protocol, which we will discuss later in this video. We also would like to identify risk factors early in patients that would be at risk for postoperative retropharyngeal hematoma. Risk factors include ossification of the posterior longitudinal ligament, longer surgery time, and multiple levels. This is the typical approach performed during an anterior cervical discectomy infusion. Typically, there's a horizontal incision on the front of the neck. This is closed with a subcutaneous monocryl suture that would be encountered upon initially opening the incision. The platysma is a thin layer of muscle which is often closed underneath this. This can be opened as well using a hemostat. The finger is then inserted into the plane shown above, where the hematoma can often be palpated and evacuated. Here's a CT scan demonstrating a retropharyngeal hematoma following anterior cervical surgery. On the right, with the asterisk, is the large hematoma, which is displacing what is typically a midline structure of the larynx, as seen with the plus sign. Following evacuation of the hematoma, we again want to be able to recognize the appropriate landmarks for placement of an emergency cricothyroidotomy if necessary. The most prominent and palpable area is the thyroid cartilage, also known as the Adam's apple. While running the finger along the anterior portion of the neck towards the chest, a small divot or valley can be felt that is soft compared to the thyroid cartilage. This is where the cricothyroidotomy site would be done, also known as the cricothyroid membrane. Below that is the cricoid cartilage, which is the last ring of cartilage which can be felt in the anterior aspect of the neck. Our no strikeout anterior cervical airway management protocol is a streamlined protocol for patients that have undergone anterior cervical discectomy and fusion, as well as other anterior cervical spine surgeries. This has been developed based on available ASA guidelines, literature, and extensive experience performing outpatient cervical surgery. The events leading up to initiation of the strikeout protocol may vary. In patients who have undergone anterior cervical surgery, signs such as difficulty and worsening of breathing, increased swelling of the anterior neck, and even deviation of the trachea may present if there is a retropharyngeal hematoma present. We encourage staff to involve the anesthesia and surgical team early in the course of treatment if there is concern for impending airway compromise. However, once the decision is made to initiate the no strikeout protocol, the team should move quickly to alert the appropriate staff, have the crash cart with tracheostomy kit at the ready, and also alert the operating room should the incision have to be opened so a formal expiration may be done once the airway is secured. Following initiation of the no strikeout protocol, the initial step is to attempt an intubation. This may be difficult, however, if there is significant tracheal deviation or swelling secondary to retropharyngeal hematoma. The second phase is an open sweep of the surgical site. Standard PPE gloves may be utilized for this. The incision is opened either by hand or spread with a blunt instrument, and the hematoma is digitally removed. Once this is done, a second attempt at intubation may be attempted. If this attempt fails, we consider this strike 2. At this point, we would proceed to the emergency tracheostomy, which we will demonstrate the technique for in this video.
So after the no strikeout airway protocol has been initiated, the anesthesia team will first attempt an intubation in a normal fashion. If they fail this technique, the assistant to the anesthesia team member should remove the surgical dressing that is present in anterior cervical spine surgery. This will make present any relevant anatomy. At this time, you might want to look for localized swelling at the site of the incision, look for fullness, and then the airway, pharynx, and anatomical components may be visualized. This is the thyroid cartilage. This is the cricoid cartilage. The area in between is the cricothyroid membrane, which is where you will make your incision for a cricothyroidotomy if needed. After the anesthesia team fails the initial intubation, that is strike 1. The assistant will move on to the next step of the procedure, in which the surgical incision is opened. The first layer of an incision is usually a running stitch, and this can be opened gently with a hemostat agent. You will see that the incision is now open. The key component is next a finger sweep, in which the assistant puts their finger directly behind the esophagus and the trachea and directly onto the spine and sweeps the finger down to open the cavity to allow drainage of any blood that is present. At this point in time, the anesthesia team member can again attempt intubation. If intubation fails on this attempt, this is strike 2. Since there are no strikeouts allowed in anterior cervical airway management, we now move to the cricothyroidotomy. We will expose the anterior surgical incision to the point that we can feel the cricothyroid membrane. We will then obtain our cricothyroidotomy kits either via 2 manners. 1, the material contained in the crash cart, which we will show you here, or 2, via the supplies on the anesthesia typical table in the operating room. First, the crash cart. Feeling directly between the thyroid cartilage and the cricoid cartilage, the assistant can make a stab incision in the cricothyroid membrane.
Here we have a prosected cadaver with an incision centered around what would be typically 5-6. We're easily able to identify the thyroid cartilage once the incision has been split. The cricothyroid membrane is then easily identifiable and palpable. If during a cricothyroidotomy the decision is made to place an incision through this membrane, a transverse incision can be easily created and then spread with available blunt instruments.
At this point in time, once this hole is present, a guide with an endotracheal tube can be inserted directly into the airway. This will pass easily without resistance to the surgical incision. The guide can then be removed, and then the endotracheal airway can be established with a bag mask ventilator. The other option is if this is not present and you are in the anesthesia room, you can use the bougie on the anesthesia kit. Similarly, make a similar incision in the cricothyroidotomy membrane. And then use the bougie to gain entrance into the pharynx and trachea. And then using this as a guide to place the number 6 endotracheal tube, which is present on all anesthesia tables. The balloon is then inflated with a syringe. The bougie guide is removed. And the airway is kept patent. And the bag vat mask is used to ventilate. At this point in time, the patient would be taken to the operating room, and the surgeon would perform a surgical exploration, hemostasis, and irrigation as necessary.
The Cervical Spine Research Society hopes that this streamlined algorithm helps you and your medical staff manage this potential complication of retropharyngeal hematoma after anterior cervical spine surgery. Please take this video and show it to your anesthesiologists and recovery room nurses. Consider this part of our culture of safety. Consistent with this culture of safety, the CSRS appreciates your feedback and suggestions on how we can make this better. Please voice your opinions on our website. Thank you for your time and attention. On behalf of all the members of the CSRS, we wish you a good day.
Very good. All right, now we're open for discussions and questions on the posterior session and the complication session. Yeah.
Sasso, I had a question about this last video. What percentage of retropharyngeal hematomas that aren't treated well by just the digital exploration? What percentage actually require a cric? What basically we get to strike 2 where they actually need the cric? Because I've never heard of anyone. I've never heard of the cric for a retropharyngeal hematoma.
Oh. Well, it's a good thing you're here, because you can save somebody's life with this. Here's the problem. The incidence of a retropharyngeal hematoma, number 1, is low. The incidence of a retropharyngeal hematoma that actually causes significant airway restriction is low, and people who die are low. But 1 person is too much. And the problem is there are enough people, and I will tell you that the experienced guys with 30 or 40 years have seen retropharyngeal hematomas. And the problem is if they're not managed in the appropriate place and facility, people die. And it's now 3 years ago. This is a big deal. I don't know if you guys remember this. You got young guys may not. Us older guys, it hit us in the face. It was on USA Today. It was in our local newspaper front page for about a week period of time, where it was all about outpatient surgery centers, but really it was the people who die in outpatient surgery centers are those with retropharyngeal hematomas that asphyxiate because no one knows how to take care of them. Now, I will tell you, it's not just surgery centers. This happens in big hospital ERs, and it happens in big hospitals on the floors with nurses and doctors all around. And we may discuss anterior cervical operations done in an outpatient setting versus NP. I will tell you just my experience. If I'm going to have an anterior cervical operation, I actually want it downstairs here, because at any one time we have at least 4 or 5 spine surgeons that know this, and at least 3 or 4 anesthesiologists that know this, and all of our nurses know this.